And all of that's been well documented. And Kenneth mentioned this just a moment ago. The work of Cordero from Spain has totally proven everything that we've said about mitochondria. So why do they have pain, mitochondrial dysfunction? And the same reason why they have the fatigue. Then the question becomes, well, why do they have the mitochondrial dysfunction? Do all of these people just carry some genetic defect and all of a sudden they all decide to develop mitochondrial dysfunction? Or is there an underlying cause? I think the research is pretty solid on that underlying cause being bacterial overgrowth. If that were true, you should be able to treat these patients with a non-absorbable antibiotic and see clinical improvement, and that's been documented many times. Whether the antibiotic is neomycin or rifaximin, non-absorbable antibiotics, if they produce clinical benefit in patients with fibromyalgia, that kind of proves the cause and effect relationship between what's going on inside their guts and how that's being manifested in their muscles as muscle pain, fatigue, and mitochondrial dysfunction. So then the question becomes, how would that happen? And we already talked about that. A lot of toxins produced by gastrointestinal bacteria are absorbed systemically and they affect mitochondrial function. And you could imagine the synergistic effect of those toxins working together, like D-lactic acid. So a study was published in 2009 showing that patients who have chronic fatigue syndrome, obviously tightly related to fibromyalgia, they have small intestine bacterial overgrowth of bacteria that produce D-lactic acid, and it was the Enterococcus that you mentioned, the gram-positive bacteria. Well, if they also have bacterial overgrowth with gram-negative, that produces endotoxin, which is another mitochondrial poison. And then the one that no one seems to talk that much about, which I think is relevant, is also hydrogen sulfide, H2S, is another bacterially derived mitochondrial poison. So that's how small intestine bacterial overgrowth can affect systemic health in general and mitochondrial function in particular, is by poisoning the mitochondria. So I think that's a great approach. I think that's the dominant model for fibromyalgia, in my opinion. Yep. Sure. So typically the dose for 5-HTP is at least 50 milligrams up to 300 milligrams. So if you look at the studies, for example, that have used 5-HTP in the treatment of obesity, what they're trying to do is push the serotonin pathway so that people feel more satiated and therefore they have less appetite. So I believe that the doses have kind of capped out at 300 milligrams. I think that's a lot. And they're doing like 100 milligrams 3 times a day. I think that's a lot. I get sleepy with 50 milligrams, I'm knocked out. And that's because obviously 5-hydroxytryptophan gets converted into serotonin, serotonin into melatonin, melatonin does a lot of great things, as Kenneth said, for mitochondria. So melatonin stimulates complexes 1 and 4 of the electron transport chain. That's one of its ways of helping these patients with fibromyalgia, in addition to just letting them rest. And sleep itself has an antidepressant effect. SAMe, I don't really use that clinically, but I know who's going to talk all about SAMe tomorrow, and that's Dr. David Hasse back there. So he's going to talk all about SAMe. I personally don't use it, and that's one of the great things about having multiple speakers up here is we all do different things, right? Like Decker Weiss was up here earlier. His approach to treating hypertension is completely different from mine, and I was just thanking him for that, right? I mean, I don't want everybody to just get my opinion. That's why I invite people who do things differently from myself. So did you have any other questions about doses? Creatinine, I think it's, is it? So he was saying 5 grams. I actually, right. I'm actually going to talk about creatine a little bit tomorrow because several studies have shown that it's not only beneficial for patients with fibromyalgia, but also that it just improves cognitive function in general. So then we could talk about how to push that pathway in the most safe way possible, whether we need to use methyl donors and things like that, because that whole arginine, creatine pathway drains methyl groups and ultimately elevates homocysteine levels. So we could see a short-term benefit in short-term studies that could translate into long-term toxicity if we were to use that as a long-term supplement. Ginkgo? I don't know the dose on it, even though I use it, but I've been using the same product for so long, I just use 2 pills of that thing on the shelf. And, you can use, I think it's 50 milligrams of the terpenoids. I'm sure the naturopathic doctors, or at least the naturopathic students would know. But I just don't know the dose anymore. And, you know, we all have to learn doses when we're in school, but then in practical application, it's like, take 2 of these and call me in 2 weeks or something like that. Sure. So that's our famous Michael Gonzalez. He's going to talk on Friday about mitochondrial dysfunction. So he was saying that the creatine works best with B complex. This is his comment. Let me get into my last presentation. Today's kind of our long day. I think we all know that by now. And open recent. I would love to open recent presentations here. Somehow mine got closed out. All right, let's see what we get here. No, I don't want to do that. All right, let me see what I can do here. That'll do it. All right, so this is our last presentation of the day, and this is one of my favorite topics, and this is the first time I've ever given this presentation. Even though, like I said, it's one of my favorite topics, I discussed this in my rheumatology book, and obviously I'll be discussing it more in the next edition, which should be due, according to some people, it should have been due last month. But I'm trying to get it done as soon as I can. So let me time myself just so we can not overextend our overextension. So we've all talked about, again, our afternoon presentations mostly centered around management of conditions that are often treated with drugs or the integrative pharmacology of those conditions, meaning what do we do when patients already come in, they're on medications, how can we get them off of their medications, what are the side effects of those medications so that we can put things in proper perspective. A lot of times nutritional interventions are kind of denigrated as being less scientific. Well, look at the facts that have just been presented to you. The standard medical care for osteoarthritis, as Dr. Centrone showed us earlier, it actually accelerates the disease, right? Well, we can't and shouldn't accept that as a standard when it's actually causing damage. So, again, my favorite topic are these autoimmune and inflammatory conditions, and what I'm going to talk about here is mostly relevant to inflammatory conditions, but it's not exclusively relevant to inflammatory conditions. As you see this paradigm become stronger, this model become stronger, I think you're going to see that this has more applications beyond autoimmunity. Like maybe we'll start doing this for our patients with allergies, and maybe we'll start doing this for patients with insulin resistance at some point. For example, I talked about the Th17 cells being important in autoimmune type inflammation. Well, you see the same imbalance, Th17 dominance, or relative dominance, you see that same imbalance in kids who have metabolic syndrome. So that's why when we talk about systemic inflammation and sustained inflammation, I don't like to look at those as hypertension and diabetes are over here, allergies are over here, autoimmunity is over here. I truly believe it's a continuum. And the research supports that quite strongly, in my opinion. So our objectives for right now, we're going to talk a little bit more about dysbiosis-induced autoimmunity and inflammation. We're going to talk about some antimicrobial agents, and we're going to talk about modulating hormones, which I think is all fun. I'll make sure that since I already have the website listed right here, let me just make sure that everybody has access to the notes for today and for tomorrow. So our website is ichnfm.org. If you go / and then just type in the word today, that should open a folder that lets you download the notes that we've used today and that we'll be using tomorrow as well. Which the notes for tomorrow aren't uploaded. I know we have some modifications coming, but they'll be up there tonight. When you're in your hotel, if you want to download the notes, it's certainly a good chance to do that. So, I think this is the cool of the cool when it comes to scientific geekiness. I realize that I just think this is great stuff. First time I saw this picture, I was totally fascinated, right? That's awesome, right? So, let's see, what do I say here? You need to know what this is, what it does, and how to kill it. All that's true. Especially if you're treating autoimmune patients, this stuff is running their life. This is the answer that we've been looking for. If you want a very simple, so I like simple models because they help us explain things, and we always appreciate that things are much more complex than that. However, this is a beautiful, simple model. And so what happens when we are dealing with something that's complex? You know, one of the ways to decipher and deconstruct something that's complex is to simply overlay multiple simplistic models. So I'm going to show you a simplistic model here that actually works. And I'm not saying it accounts for all autoimmunity, but it's a contributor. So these are called segmented filamentous bacteria. I believe they were just discovered about 2 or 3 years ago. They're non-culturable, so those of us who do stool tests, like me, we're never going to see these. They're non-culturable, but you've got them. Well, I hope you don't have them. Some of you may have them. Some of your autoimmune patients have them. I don't know if it's true that everybody has them, but they are found in humans, and they cause problems. So we're gonna kill them. Evidence-based medicine, as you can see here, typically has 4 components. 4 components are patient's preference, doctor's experience, clinical research, and kind of what we have to do to accommodate the situation. You know, standard of care in rural Tanzania is going to be different from New York just because different things are available. So we have to take all those into consideration when we're describing this thing called evidence-based medicine. I would love to see that menu bar disappear, but that might not happen. And it might not really matter that much. There's the functional medicine matrix. You've all seen that before. So clinical applications, we already talked about this. So you want to define the duration of treatment, look for drug interactions, disease interactions. You want to ask yourself, does this patient need a referral? And obviously you want to document all of that in the treatment plans. And obviously sign and date and you know, maintain good records with your treatment plans. I've seen some doctors who are going through a review process and they don't even sign and date their charts, and it looks really bad. So let's see. My way of teaching the management of autoimmune conditions in the rheumatology books that I've written is to always recommend that patients are co-managed with the rheumatologist. That's because these patients with these systemic inflammatory conditions like lupus and rheumatoid arthritis, they can develop complications very quickly, and the answer is they need steroids now. For example, giant cell arteritis, temporal arteritis can result in blindness very quickly. Somewhat similarly, and I've had 2 patients with this, I've had 2 patients develop what's called transverse myelitis, which is inflammation of the spinal cord. Those patients can go from a little bit of symptomaticity, meaning like a little bit of numbness and tingling in their fingers, to paralyzed within 48 hours, right? So that's why I like to have these patients co-managed. So we're going to follow the same protocol that we talked about this morning. Right now we're going to focus on dysbiosis and endocrine imbalances. And I'll show you some of my favorite treatments. And I'll also show you the results that I've gotten in some patients. I had a really interesting case. It's the one that I started to share with you earlier today. About that patient who had the severe rheumatoid arthritis. She had the CCP of greater than 250. She did a 26-day water-only fast with no results, other than weight loss, which of course is good. And then I put her on the protocol that we've already defined, and she got significantly better. But then when we added this is what we added, the things I'm going to talk about right now. This is what we added to her plan, and this is when she got significantly better. Now, how would we prove that fact? How would we prove the fact that my treatment plan got her better? Well, we could withdraw the treatment and then see if she gets worse, right? So I would never do that because I'm nice. But the universe withdrew treatment, right? So when she was going through some financial transitions and wasn't able to maintain her medications, she got off the medications for a little while and she started to regress clinically and with her lab results. So that proved to us that we were on the right track. So again, I'll show you what we did with her case. Lots of articles talk about the connection between microbes and autoimmune disease. You've seen that I've summarized some of them here. I could summarize hundreds of these articles. But the fact is, I think, based on the research, I think the research supports the fact that there's always a microbial component to autoimmune conditions. Definitely true with psoriasis. I mean, all of them as far as I'm concerned. So, as we said before, or as I said before, often what we find when we're working with these autoimmune and inflammatory patients is that they're having a pathogenic inflammatory response to a non-pathogenic microbe. So what do we do about that? Don't even look at your notes, because it's not on this slide. So what do we do about this? Because we talked about it earlier today, right? If this is the